Okay. Oh, okay. So welcome. This is the Oregon Psychiatric Access Line for Adults Training with Dr. Betlinski. And we are going to go ahead and get started. We want you to mute your mics. We are have a smaller group today, so if you have a question while Dr. Betlinski is talking, you can go ahead and unmute yourself and ask that question, or you can add your question to the chat to be answered at the end of his presentation. We are going to be following up with an email with the slides, with a recording link, and any other materials that come up today that Dr. Betlinski wants us to send off to you. And this recording will live at our YouTube channel for the Older Adult Behavioral Health Initiative. Live attendance is required for the CEU that we're providing. And PSU does our evaluations, so you'll get an extra evaluation email from PSU, and it's the IOA evaluation email address. So if you see something from that, know it's part of this. So the Older Adult Behavioral Health Initiative started in 2015, and we are a group of specialists, 24 statewide, and we have a number of us today here on the call. We do collaboration and coordination within different systems of care. We also build knowledge capacity through workforce development trainings like this one, and then we also do health and wellness promotions out in the community. And we provide complex care consultations for anyone. And you can check out our website at oregonbhi.org. And just to let you know, we have an upcoming training on addressing social isolation, loneliness, and connection with Morgan Merler from the Foundation for Social Connections. And that's a national organization, and they're going to be talking about their different strategies and a framework that they have developed. Okay, so I'm gonna go ahead and hand this off to Dr. Betlinski so that you can share your slide and give a little intro, your own bio, because I noticed you have a slide.
All right, perfect. Let's attempt to share screen here. Share. All right, can you guys see okay? Do you see my entire title slide with nothing being blocked out or anything like that?
Yep, you're good.
Perfect. All right, here we go. Well, we're here today. Good morning, everybody. Happy first Tuesday in November. May all your dreams come true. But we're here to talk this morning about the Oregon Psychiatric Access Line. I have no relevant financial disclosures. Of course, I work for the Oregon Psychiatric Access Line, and if we discuss medications today, it probably will include some off-label stuff because oftentimes OPAL calls include off-label discussions of medications. I get to be a lot of things. I'm an academic. I'm a professor, and in true academic fashion, wear a lot of hats. For the purposes of today, you should know that I'm the medical director for the Oregon Psychiatric Access Line about adults, and I get to do really cool other things too. My favorite is being on the board of one of the summer camps here in Oregon. Here's what I hope to accomplish in the next 40 minutes or so. I want to describe the history and the role of the Oregon Psychiatric Access Line, make sure that you know what to expect if you call OPAL, and also give you lots of data about how OPAL enhances participant knowledge, confidence, and competence when screening, diagnosing, and treating mental health disorders. Let's lay just a little, let's put a little bit of seed in the ground here in hopes of getting a good crop. First question, when did the Oregon Psychiatric Access Line begin accepting calls about Oregonians of all ages? Second question, which of the following professionals are able to call the Oregon Psychiatric Access Line? Nurse practitioners, pharmacists, physicians, physician associates, or all of the above? And third question, in which of the following ways does the Oregon Psychiatric Access Line improve quality of care? Is it that you have to call them to get permission? Is it that you can access electronic health records through us? And so on. If I do my job right, you will know the answers to all three of those questions by the end of today's time together. Let's get the lay of the land. Some of you might remember back in 2020, a very cute, well, technically late 2019, a very cute, thistly looking virus entered the world and totally changed it almost overnight. Rates of depression and anxiety in our country nearly quadrupled, and they really haven't receded much. They've held pretty steady, and indeed, if you look at where we are now, there's Oregon in the upper left-hand corner. About 1 out of 3 Oregonian adults are reporting symptoms of anxiety and or depression as of late last year, which is the latest statistics that we have available. This data is getting a little bit dated. It came out about the same time as the pandemic hit, but just reminding us that psychiatrists and addiction medicine specialists are not well saturated or spread around our country. And indeed, Oregon has about 1 for every 7,500 to 8,000 people or so. That is a heck of a caseload if you happen to be trying to take care of your share of folks. Speaking of Oregon, let's zoom in a little bit closer to the nature of the problem in Oregon. As you know, Oregon is a place characterized by high population density in a very few places. Most of Oregon is considered to be either rural, or if you're going by square mileage, about half of our state is frontier, which means 6 or fewer people per square mile. And if we're looking at the availability of medical services, much of Oregon, again, you can see here on this map, the population centers are those areas outlined in pink, but most of Oregon is either medically designated as a medically underserved area or a medically underserved population, depending if we're looking at people or geography. Now, Oregon's population is growing, and so you might be either optimistic that the healthcare workforce has grown in proportion, or that maybe population growth is outpacing the healthcare workforce, and you are right on both sides of that equation. If we're looking at mental health, at least through 2022, the numbers look pretty good. Counselors and therapists and clinical social work associates are among the fastest growing portion of our healthcare workforce. The challenge is when we look at where those folks are entering the workforce. So to compare us to primary care, if you look at raw numbers, we've got almost 14,000 behavioral healthcare professionals. It's the largest segment of our healthcare workforce here in Oregon, and that far outpaces primary care, coming in at just under 9,000. But if you look at how much people are actually working and where they work, those numbers change very quickly. For instance, the average behavioral health professional in Oregon works about 0.55 FTE. And then if you look at where people are apportioned, you can see that in the metro areas like Multnomah County, the very sort of top of the map at the very dip, we have 31.9 behavioral health professionals per 10,000 people. That easily outpaces primary care at 20. But if you move out into rural parts of the state, you can see that very quickly those roles reverse, and primary care is present in far greater proportion than behavioral health. No surprise then that primary care in Oregon takes care of the vast majority of behavioral health needs. This is data that came out pre-pandemic, so I would expect the numbers to be even more stark now. But in 2018, we looked at, HRSA looked at all the states, and here's the data from Oregon. And you can see that psychiatrists, there were not nearly enough psychiatrists in our state. And when they predicted ahead in 2018 at what 2030 would look like, that was even worse. Now that gap is made up by PMHNPs, nurse practitioners who specialize in behavioral health, and by the growing number of PAs in our state who specialize in behavioral health. But if you skip over to the right side of that chart, you can see that even with the growth in PMHNPs and psych PAs, and even before the pandemic and the resultant rise in behavioral health needs, we were not predicted to have enough behavioral health prescribers in our state by the time we get to 2030. It's perhaps no wonder then that Mental Health America still has some strong criticisms of Oregon in our 2024 mental health rankings. Now, to be clear, we are much better. We have rocketed from number 30 to number 6 on access to care. We've rocketed from number 48 to number 35 in adult ranking. We've rocketed all the way from 51 to 49 in youth ranking, and we've climbed to 47 out of the 50 states over all 50 states and Washington, D.C. We now outpace not just Kansas, but Alaska, Montana, Arizona, and Nevada. For those of you doing math, you realize that Kansas managed to leapfrog us, going from last place to a little bit higher than us in the state. But to be clear, we are much better than we used to be. But keep in mind, we are still 51. We are the state that has the highest prevalence of mental illness and substance use disorders in our country. So we have a lot of room to grow. All right, we understand the various layers in Oregon. Let's go ahead and paint a picture of the Oregon Psychiatric Access Line, since that's why we're here today. What is OPAL in short? OPAL is a free to callers, same day access to peer consults, which means if you have the legal ability to prescribe medications in Oregon, you can call the Oregon Psychiatric Access Line free of charge. There will be no charge to insurance or clinic or anyone else. This is your taxpayer. This is your tax dollars at work. These are funds set aside by the legislature through OHA. We are available 9 a.m. to 5 p.m. on non-holiday weekdays. There is one child and adolescent psychiatrist, sometimes two. We've gotten some money for additional staffing. 2 adult psychiatrists, the medical director for each half, backing those up. We now have developmental behavioral pediatricians as well. And so you can call and be transferred almost immediately to a psychiatrist. The psychiatrists who work these hotlines or work this hotline, that is their primary clinical responsibility. So you don't have to wait for them to finish up with a patient or be called away from something else. Their job is to take your phone call and talk with you as short or as long as you want about anything related to mental health. All right, so if you have a patient with a mental health challenge and you would like some guidance to talk about that, then you're welcome to call us. It doesn't matter where they are, as long as their health insurance is through Oregon, or if you're treating somebody, if you are a provider who's, let me say this more clearly, if you are a provider who is in Oregon, you can call us. If you are treating somebody who has their health insurance through Oregon, you can call us. So we do get calls from surrounding states as well when people with Oregon health insurance go outside of the state. All right. Initially, OPAL opened up in 2014 as OPAL-K. It was a collaboration between the Oregon Pediatric Society and the Oregon Council on Child and Adolescent Psychiatry. And in 2018, we got additional funding to expand to Oregonians of all ages. We also have some other specific programs as well. We help out with a foster care system and the antipsychotic monitoring program for kids in our state. We've added developmental and behavioral pediatricians. That one's a bit different. You have to call and schedule an appointment because we only have a few half days of DBP time. And then also, if you are, we in 2020 launched OPAL-C. If you want to call us and talk about yourself, you're welcome to do that as well. You can call and talk about yourself or a family member. We clearly don't keep the same detailed records of those phone calls. We just track how many come in. But it's essentially as if you walked up to me in the hallway and said, hey, Betlinski, I got to talk to you about something. Do you have a couple of minutes? All right, here's how OPAL works. Again, we're open 9 a.m. to 5 p.m., except most national holidays, who are interestingly enough open on Veterans Day. So you can certainly call us that day. You would call our number, and one of our folks will answer the call and get some very basic patient demographics. So we do ask for things like name of patient and date of birth, and the state asks us to track what their health insurance is, so that they can have some idea of whether a particular health insurance company is, their providers are disproportionately calling us. And as soon as we've got those demographics, boom, you get transferred over to an OPAL consultant. So when I look at the data, almost every single one of our calls is transferred within 5 minutes. Why is it within 5 minutes? Because that is the lowest amount of time we count. It's almost always less than that, but the box for less than 5 minutes gets checked. You talk with the consultant as short or as long as you would like. And then we will write a summary at the end of that phone call. We try to get it to you the same day. Sometimes it's the next day if we've gotten slammed with phone calls. And that summary will say things like, here's the nature of the problem you talked with us about. Here's the clinical recommendations that we talked about, medication recommendations, non-medication recommendations, monitoring recommendations. Oh, and by the way, here's some other stuff. For instance, we have a whole collection of treatment guides that we've put together and some that we've gotten with permission from others that we will send out to you to be helpful as well. And then that summary comes to you either by fax machine if you've requested we send it that way, or by secure email if you've requested we send it that way. Another slide reminding us for the call summary outline. Our unofficial motto is that there is no question too big or too small. Some phone calls take literally 2 minutes. The simplest phone call I ever got was from a primary care provider calling to say, gee, my patient has been on fluoxetine 20 milligrams now for about a year, but they still have some symptoms of depression. Would it be okay for me to increase that? Very short, routine phone call. Some calls are incredibly complicated. The very first phone call that we ever got for OPAL-A was out of Klamath Falls, about a 21-year-old first-time mother with a history of anorexia nervosa. Her symptoms had flared up in the postpartum period. She was losing weight. Her baby had stopped gaining weight. So sometimes phone calls can last a long while. Sometimes they're very routine. Let's dive into the data and get a little bit below the surface of OPAL. As you can see, a whole lot more people are registered for OPAL than actually call us. It's a little unclear why that is, because we get our best data from the people who actually call us as opposed to from the people who don't. Disproportionately, registrants come from Multnomah County, but that's no surprise. That's where the highest concentration of both providers and patients is in our state. Most of our, or about half of our providers are MDs. We have, if you add in DOs, then physicians clearly make up the majority of our registrants, but the rest of the registrants come from across the spectrum, including some pharmacists. As you know, clinical pharmacists can prescribe medications in our state, and so they are eligible to call us as well. Call volumes have been steadily increasing. We anticipate that 2024 will, this is data through the first 3 quarters of 2024, and so it looks like we're on track to exceed our call volume yet again at OPAL-A here in 2024. The most common diagnoses in the US and in Oregon are depressive and anxious disorders, and that is far and away the biggest proportion of our phone calls. But if you dive further down in the data, like if you look at schizophrenia spectrum and other psychotic disorders, that's probably around 1% of our population, but clearly way more than 1% of our phone calls. Not surprise. No surprise there. Those cases can be more challenging, and so we're more likely to get phone calls about those. Most people who call us have more than one, or most cases we discuss have more than one diagnosis. So this is not a one-to-one correlation. Most of our phone calls are about people in the 26 to 40 age range, but as you can see, since we're here talking about older adults today a bit, that accounts for a big chunk of calls that we get, including people who are over the age of 75. Some of you are wondering why I'm showing you OPAL-A data and I'm showing a category 0 to 17. That is because if somebody is under the age of 17, or excuse me, if somebody is between the ages of 14 and 17 and the OPAL-K consultant is busy, we give the provider the option of talking with an OPAL-A consultant instead. And so we get a few hundred, or we've had a few hundred calls about people between the ages of 14 and 17 that get routed to OPAL-A. Again, Multnomah County is by far and away accounts for the majority of our phone calls, but if we divide up the data by calls per capita, so we pair the calls with the population of a county, you can see that the picture looks very different. You get a lot of phone calls from North Central, from Southern, from Northeastern Oregon, and Multnomah begins to fall down the pack there. Josephine County, if you happen to be in from Josephine or Curry County today, you got some work to do. Give us a call. We'd love to talk with you. I'm going to just dial down a bit now and look at rural providers. This data, we haven't yet looked at 2024 because we want to look at the whole year, but you can see that our calls from rural Oregon are growing steadily as well, and we anticipate that will be the case again this year. One of the questions that we always ask our callers, or at least we ask our consultants to always ask our callers, is about suicide. It doesn't get asked every time, but you can see that the majority of our calls don't involve any suicidality, but there's a big chunk that do, and we can help you think through those things as well. Another call that, or another category that we always ask our callers about is about trauma and whether trauma might be influencing the current presentation as well. And you can see that about a quarter of our patients have a history of trauma. And if you look at trauma, a history of trauma and trauma causing symptoms now, then we get closer to about a third or so, almost a fourth of our, or excuse me, almost half of our patients have trauma as a part of their presentation. Whether it's really affecting what's happening right now or not may not be clear.
Dr. Betlinski, we have a question from Paul about providers,
Yes.
actually.
Let me get to the chat. Or can you just read it to me, or do you want me to get to the chat box?
I can read it to you, and maybe Paul can come off mute and say a little something about that.
Paul,
I'm
tell
happy
me
to
your
read
question.
it. I just didn't know if we were going to interrupt or not. So, yeah, I'll read it. I was just going to say one thing I've become aware of is that all psychiatric prescribers have biases from past training. I worked on a local psychiatric unit and was precepted by a few psychiatrists who were excellent, but each one had different views depending on where they went through. So, one of the questions I asked or want to ask is, have you guys thought about that, or do any of the prescribers that work for OPAL-A have industry ties? I know that you said you don't to the pharmaceutical industry, but I know that would affect probably some of the recommendations given.
Yeah, what a great question. And the answer to that is no. We make sure that all of our OPAL consultants meet CME criteria, and OHSU automatically excludes anybody with industry ties from being able to do continuing medical education.
Thank you. Cool.
And now that doesn't take away the differences in their training or their own personal experiences or things like that. We do meet regularly as OPAL faculty and discuss complicated cases together and talk about how we would handle those and come to, so we learn from each other, but we have different specialties. So one of our OPAL consultants is also a forensic psychiatrist. We have an OPAL consultant who's also a geriatric psychiatrist. We have folks who specialize in various different things, some who've spent most of their career in inpatient, some who've spent most of their career in outpatient. We have one who specializes in LGBTQ care. And so we like that because it helps us learn from each other, but it also means that in addition to the plethora of folks down the proverbial hall at OHSU that I can call and discuss cases with if it's above my expertise area, we have those folks right in OPAL as well.
Thank you.
Yeah. I'll dive back to the data now, which was to remind us that perhaps not surprisingly, most of the cases we discuss at OPAL are about people who are not enrolled in mental health care in any way, shape, or form. So they don't have a therapist, they don't have a psychiatric prescriber, or anyone else with behavioral health involved in their care. It really is just the caller who's calling us, usually their primary care provider, who's managing their behavioral health condition. Most of the time, the person who calls us is comfortable continuing to be the primary person managing that behavioral health care issue after the call, but occasionally we do make other recommendations as well. There has been sometimes this idea that OPAL calls last way too long and we can't fit them in, and I just want to reassure you that the majority of our calls are 15 minutes or less. But some calls do go for quite some time, and we did have one call in our history that has lasted over an hour. We stay on the line. We don't require you to stay on the line. We stay on the line as long as you would like to. And sometimes callers save up a call for the end of their workday or for a day when they have administrative time so they can really have a thorough discussion with us. We are beloved by the people who love us. You can, or by the people who give us feedback. You can see that the majority of our callers find the consults to be useful, feel that they're treated as a professional, and that they get to talk to somebody very quickly, and they get valuable help with their case. But again, I can't tell you about people who don't call us because I don't have that data. To give you just a little bit of subjective stuff, here's somebody from Jackson County who said, "I'm so grateful for the OPAL consult line. It's such an incredible service, particularly for rural areas. The OPAL consult line fills such a gap in primary care. If we cannot get patients into specialty mental health care, it's a huge asset to the state." Here's somebody from an unincorporated community in Lane County who said, "I absolutely could not take care of patient psychiatric needs without OPAL. I'm a new grad at a rural clinic, and for various unanticipated reasons, I'm the only provider there." And finally, someone from Klamath County, love OPAL, so valuable, especially for rural PCPs with poor access to psychiatric care. Here, by the way, if you don't want to take notes, you can just scan the QR code with your phone from your computer screen. That'll take you to our website. You can call anywhere in the world, or at least the US, toll free, or if you're from the Portland metro area, we give you a local number that you can call as well. Again, you can call us anytime from 9 a.m. to 5 p.m. The very first time you call us, we'll have to register you, so feel free to call ahead or ask somebody from your office. If you're an administrator, gosh, you could just register all the providers from your clinic at once and save them that couple of extra minutes from the very first phone call. All right, just a reminder that we, particularly in the rural places of Oregon, it can feel sometimes like we're a little bit all alone, but that is not the case. A reminder again that we have OPAL-C. You can call us and talk about your own stuff. It might be that you just had a really difficult patient encounter and you need to process that with somebody, or you've had a rough day, or it might be that you're worried you're developing your own mental health diagnosis and want to brainstorm how to proceed and get some help for that. You can call us and talk about that as well. We do not keep records of those phone calls. We just count how many come in. So it really is a peer consult about that. We don't take over your care, but we can help you figure out where to get care if that's what you need. I also want to tell you about a couple of other resources that I think are really valuable. One is the MHCAG. This is a group put together by OHA, and we are, of course, required by statute to cooperate with them and them with us. The MHCAG is a multidisciplinary committee that puts together treatment guidelines for how to manage medications in mental health diagnoses. They also make official pharmacy recommendations for OHA and things like that. They have a whole bunch of practical help about anxiety disorders and bipolar disorders and depressive disorders and psychotic disorders and things like that. So I encourage you to check them out. You be not surprised if you call us about something that has been addressed by MHCAG. Will likely include their treatment guideline or at least some relevant part of it in our write-up when we send it to you, so you'll have access to that as well. Also here in Oregon, another free resource is the Oregon Echo Network. These are usually 12-session, 1 hour a week things about various topics of interest. You can see there on the right all the different ones that we're currently offering right now and a couple of tidbits about what's coming up next, but definitely check the website. You can see what programs are upcoming. Again, this is free. Provided by the cost is covered by various grant funds and some OHA dollars and some federal funds and things like that. Free continuing education credits, AMA Category 1 and maintenance of certification credits for those of you in primary care as well. So if you want to dive a little deeper into a topic and learn more, there's a free resource. And then finally, a couple of my favorite self-help resources. These are well vetted. One, Kilty's Key on the left, comes out of Vancouver, British Columbia. It's a nonprofit that puts together online cognitive behavioral therapy modules that are free to anybody in the world about things like insomnia, depression, anxiety, and so on. And on the right, the Center for Clinical Interventions out of Western Australia has a plethora of self-help resources and really useful handouts for you to share with your patients as well. So again, another couple of free resources that I think are well vetted. Okay, it's officially time to see if the seeds that we planted at the beginning of the lecture bore fruit. First question: when did the Oregon Psychiatric Access Line begin accepting calls about Oregonians of all ages? Was it in 2012, 2014, 2016, 2018, or 2020? Well, the answer, of course, is that we first opened taking calls about kids in 2014. In 2018 is when we began to take calls about Oregonians of all ages. And in 2020 is when we began to take calls about providers themselves. All right, the second question: which of the following professionals are able to call the Oregon Psychiatric Access Line? Is it nurse practitioners, pharmacists, physicians, physician associates, or all of the above? The best answer, of course, is all of the above. And by the way, anyone else who has the legal ability to prescribe medications in Oregon. So that could be a clinical pharmacist, could be a certified nurse Midwife, I'm still waiting for our first call from a dentist, but you could be the first one if you want to be that. All right, the third question, in which of the following ways does the Oregon Psychiatric Access Line improve quality of care? Is it that non-psychiatrists must get OPAL permission to prescribe psychotropics? Is it that OPAL acts as an electronic health record summarizer? Is it that OPAL consultants provide evidence-based insights to inform clinical care? That OPAL consultants rapidly take over clinical care of patients? Or that OPAL provides low-cost medications? And the answer here, of course, is C. OPAL consultants provide evidence-based insights to inform the clinical care decisions that you make for your patient, or should I say in concert with your patient. So in summary, Oregon continues to have the highest mental health burden of any state in the USA. I think primary care providers are unfairly tasked with handling a ridiculous amount of that. We're working on it statewide, and the system is getting better. But in the meantime, services like OPAL can help providers manage their patients' mental health needs. A reminder, the only cost to you is your time. There is no charge for this service. It is officially a state service. That is my presentation, and we'll move forward to the questions in the chat box or any other insights. Oh, I could probably stop sharing, couldn't I?
Great. Thank you, Dr. Betlinski.
Have I
I did
successfully?
have a
No, I haven't.
question about
Stop sharing. There we
billing
go.
for the consultation. Can providers, is there a billing code that providers can use to capture the time that they spend in consultation?
So the answer is it depends on the insurance company you're working with. Some insurance companies do reimburse for calling and talking with a consultant, but since it's not statewide, we don't make that recommendation yet. I would urge you to reach out to the insurance companies that you work with and ask them if you can get reimbursed for this. I personally think you should, because I think you're making clinical decisions and you're engaging in conversation, but it does vary by the insurance company.
Okay. Thanks. Mary, I saw that you had unmuted yourself for a second. Was that a glitch, or do you have a question? It was a finger spaz. Okay.
I've got a quick question.
Yeah, of course,
I
Paul.
think you said there was a write-up done after the call. Is that a standard thing?
Yes.
Is that a once in a while thing? What's that about?
That is a standard thing. So we want to make sure that this. So let me give you a slightly longer answer to that question. The short answer is yes, we're going to send a write-up after every phone call. The longer answer is OPAL kind of operates in a little bit of a legal gray space. So we're not really, we're definitely not taking over care of a case. We don't talk with patients themselves, and we don't tell you what we have to do. So legally, we're an educational service or a peer consult service. It's sort of the same legal territory, again, as if you came up to me in the hallway and were like, hey, Betlinski, can I bend your ear about a case I'm working on? I want to sort of get some thoughts from you about that. So we do have responsibility. We clearly should not tell you, if you tell me that your patient's lithium level is 1.4, I shouldn't be like, no, why don't you see him next month and check it again, right? That would be bad advice. So clearly we cannot give bad advice. But one of the ways that we can make sure that we're being educational is by writing things up and saying, here's some things to think about. So the write-up almost always includes things that we didn't even talk about. Because as I'm writing up a case, I'll think additional things. I'm like, oh, here's an interesting thing that you might want to think of. But it also helps cover things, right? So this has never happened and never would happen, but let's imagine a case in which some terrible provider wants to make a really terrible decision with a patient, but they want to have some cover for that. So they document in their chart that they called us. And then they say, the OPAL consultant told me that it was perfectly okay for me to go ahead and increase the lithium dose in a patient who's got a lithium level of 1.4. So we also want to write up recommendations and say, gee, you probably should send your patient to the emergency room for this lithium level because it's going to cause problems for them, right? And so we do write up everything. And the other reason that we write things up is it gives us an ability to do quality control on our own as well. So I, as the medical director, am regularly reviewing other people's write-ups and understanding what happened. And so we do. So we have that record. It's stored very securely and all of that. But the write-up we don't have access to the medical record. So the write-up doesn't compete with the medical record. It's just a summary of here's the summary of the clinical case we discussed. Here's the medication recommendations we discussed. Here's the non-med based treatment recommendations we discussed. Here's monitoring things we discussed. And by the way, here's some additional thoughts. And so it's, it's about a page, each write-up, and we send that to you. Again, when you first register with the Oregon Psychiatric Access Line, we're going to ask you, do you want us to email you or do you want us to fax you the write-ups? And the vast majority of our consultants say send it via secure email, but some folks prefer fax, and so we'll send it to you via a fax if that's what you want.
That's great. It seems like something you can easily upload into like the document section of the EHR and reference in the future too. And that seems really cool.
Absolutely. So you are, from our perspective, you are welcome to include that in the electronic health record. We would love someday to have the ability to have it just appear in your electronic health record, but we don't have a framework to do that yet. I have I don't want to take away from your questions. Please interrupt me at any time. But since we do have a couple of minutes, I'm wondering, now that for those of you who are quite familiar with OPAL, or for those of you who are learning about it for the first time, now that you have a sort of an understanding of what OPAL does, what could we do that would be even more useful? And I ask that because we're always thinking about ways that how can we continue to even to fill in the gaps in the healthcare system, and what are the areas that we're not covering that we should be. That's how we got to DBPs added to the service, because we had enough callers say, gee, we really want to be able to talk with the DBP. What can we do even better than we're doing?
So my name's Mary Plasik. Sorry, I was late. I don't know if you introduced yourself. I'm a medical director of 3 offices in Polk County. I'm the only MD right now. I work with 2 physician assistants and 2 nurse practitioners, all of whom are relatively new graduates. Most of whom, sorry. I think specifically for my newer providers who are in situations that are a borderline crisis situation, and the county resources in Polk County are significantly limited. And so we get into situations where the only option is to send someone to, or it feels like the only option is to send someone to the emergency room. But when that happens, many times the patient doesn't go, or they don't get the care that they need, or that the provider feels like they need. And so they just, and that carries into every other episode that they have with another patient who then they feel, well, what's the point? They're not going to do the thing that I feel like they need. And so the thing that I've been asking for and trying to do is really help coordinate those kinds of services. And even just a knowledge of the available services for those kinds of things. It's harder than I had imagined it would be. And so obviously that's a big task for you, but even just having somebody within that framework, not necessarily even a medical professional for a consult, but someone who's more familiar with coordinating resources that are available to certain insurances, or what my patients, or what our patients could be eligible for, that's county specific.
I think so. Really, so may I ask you a question about that, Mary?
Yeah.
We certainly do, and I think we need to do a better job of keeping tabs on what's happening. We should probably be checking in with every county at least 4 times a year to get the latest on what's happening, and we're not doing that as well as we should. I think part of what we've given ourselves permission to be less diligent about that is that Oregon, every county in Oregon is required by law to maintain a mental health crisis line that's staffed 24/7. And I'm curious, am I understanding correctly? I don't want to misunderstand this, but am I understanding correctly that that's not as helpful as you would like it to be?
Correct.
Okay. All right.
Even in my school-based health center, where there is a guarantee and funding to plug the patient in directly to behavioral health, that doesn't happen. Again, the crisis line, person will be connected to the crisis line, and they say, yeah, just go to the ER. But at the ER, there's no guarantee that they will get any kind of care. And so it becomes a pretty pointless encounter.
It sounds to me like one of the things we could do is something that we haven't really done since 2018 when we first opened, is that we also need to market ourselves directly to ERs again and remind them that when they have a patient that shows up in the ER with a mental health crisis, they can call us. Now, we're only open 9 to 5, so they might have to sit on them for a few hours if they show up in the evening or something like that, but that we can help. Now, I can't make a dangerousness determination on somebody because I haven't evaluated them, but I can help a provider. I can talk them through what the kinds of things they would need to consider and help them. And once they've decided that they need to keep somebody in an ER, I can help them figure out how to manage that person while they're in the ER. Because as you know, it's not uncommon to spend as much as a week in the ER in a rural community in Oregon waiting for a mental health bed to open up somewhere. And the standard of care, unfortunately, in our state is you're probably not getting a lot of mental health care while that happens. And so we can help begin to make adjustments in care even while somebody's stuck in the ER.
And one last thing. I mean, I see
Yeah,
from your presentation that you're very good at accumulating and analyzing data. I feel like in those situations, as far as, you know, cataloging even the discrepancies in those kinds of resources, I'm amazed at what is available in Marion County that's just across the river from me. And I've thought about presenting that data to state legislators, but I don't have that kind of experience. Whereas I feel like you guys are in a great position to collect that data.
So yeah, so we do collect a lot of data and we share it quarterly with OHA. We have to write reports on what's happening. I will just say this as well. If you ever want to get data from OPAL to talk with your local government folks, whether that's representatives or senators or even commissioners or whatever, just reach out. We'd happily share our data with you. We consider it to be, you know, it's public knowledge, with the exception, or should be, with the exception, of course, patient names and particulars of individual. None of the protected health information is anything we can share. But the metadata, absolutely, we'd happily share that with you.
Mary, I just wonder if you could act as a conduit to connecting Dr. Betlinski and your local ER director. I mean,
oh my
whoever
gosh, yes,
is managing that MD to MD, possibly. If you can get that started.
Back in 2018, when we first opened, when OPAL-A first opened, I made it my goal to personally visit every primary care clinic in the state during the first year of OPAL-A's existence. I did not succeed because I drive an electric vehicle and there were some places that I just couldn't get, and sometimes weather got in the way and things like that, but I came darn close. Apologies to the Medford area. There were no electric vehicle chargers in Medford, so that one kind of, I got Ashland, I got all the communities around, but I couldn't get to Medford. And there were some, you know, other places that we didn't get. But please know that if there is anybody you want me to talk to, I will show up in person. I will figure out a way to juggle my schedule to get there in person, to talk with whoever I need to talk to, or to beam in virtually, and to chat with folks one-on-one, or to show up at provider meetings if there's a way that I can be helpful. And by the way, OPAL also, we sort of have to advertise this by email, but we don't on our website. Again, we have a ton of CME folks who do OPAL-A consulting. And so if there's a topic that you want to have addressed in a clinical staff meeting, we're happy to beam in and present. So we can, like, you know, wasn't too long ago that I talked with a bunch of folks about obsessive compulsive and related disorders, because they were seeing a bunch of those in their clinic and they were like, we'd like to know the latest about that. So we'd love to be helpful in educating your providers about stuff, that the mental health stuff that is of interest to you. So feel free to reach out to us with requests on that, and we will do our best to accommodate.
Does that mean that you could provide CME? Is that what you
we will do our best. So clearly the easiest is if you have your own CME framework set up, and then we take part in that. But if that doesn't work, I will happily try to figure out how to do that with you through OHSU's CME.
Oh, that's a nice little treat.
I will just warn you, it can be a challenge, but I'm happy to work with you to problem solve that.
I'd love to answer your question too.
Yeah,
I guess I'm a psychiatric nurse practitioner, and me and my wife, who's a social worker, own a clinic, and there's 6 of us psych NPs there. And we recently hired 2 new psych NPs. One of them's with us, Ashley, on this call.
Oh, hey, Ashley.
Yeah, one thing I want to speak to, I guess, is like as a psych NP, I feel like I can say the psych NP training is like pretty minimal compared to what it should be. And I wish psych NPs had much more training, had residencies, had lots of different things that we don't have. I happen to have the experience working on a psychiatric unit under psychiatrists, and I feel like that barely pulled me up to where I should be to know that have the knowledge I have. And a lot of psych NPs don't have that experience. So I guess I want to, and I'm probably going to try to encourage my staff, especially new grads, to call you guys,
Absolutely. Yeah.
and not just like when there's a case that they can't figure out, but almost like schedule, like tell them to call you guys at least once a week about a case, just to
Sure.
use you guys as an educational resource. And I almost wonder if there's like a place for you guys with newer psych NPs, not a residency, obviously, that's way too much, but just like some kind of regular use for educational purposes. You guys describe yourself as an educational resource or service, just to really like bolster the knowledge of psych NPs in our state. There's just so many people, psych NPs coming through schools all around the nation and online schools, and I just don't want them to provide woefully inadequate care.
What about a community of practice? What?
Paul, I really love that you raised that issue, because I do think that oftentimes the newest folks, be that nurse practitioners fresh out of training, or psychiatrists fresh out of training, or whatever, are tasked with handling some of the most complicated things, right? Because they take jobs at community mental health agencies, or in small practices in underserved communities and things like that. So please know that we are excited every time a PMHNP or a psychiatrist or a psych PA calls us at OPAL, because we consider ourselves to be just a part of the larger community, and we love supporting our colleagues. And so absolutely call. And 2, you call regularly. So like the family medicine residency down in Klamath Falls has just built us into their training. So their residents are like required to call us whenever they have somebody that they're dealing with a mental health issue. It's just a part of their mental health training. So I have no beef with other training programs around the country, or probably not the country, but around the state at least, encouraging their trainees to call us and discuss cases with us. We love when that happens, and we're excited about it. The other thing that I would just remind everybody as well on this call, for those of us who are feeling a bit rusty on something, or feeling a bit new on something, Echo is a great way to rebuild your skills as well. So the Adult Mental Health 2 Echo that's launching in January, for instance, registration is now open for that, is going to talk about things like adult ADHD and psychotic disorders, and maternal peripartum issues and things like that. So some of these issues that we maybe didn't get a lot of experience or training on, but that we find ourselves dealing with pretty regularly. And it's a great way to at least buff up your skills about that. The other thing that we're launching in January is a psychiatry community of practice. So I and Ajit Jetmalani, a very experienced child and adolescent psychiatry, who happens to be the chair of child and adolescent psychiatry here at OHSU, will be having these once monthly sessions. It'll be an hour, and anybody is welcome to beam in, and you don't even have to be a licensed medical provider. It could be a social worker, or whatever else, can come in and present cases, and we'll discuss them together as a group with whoever's there, and get some idea about how to move forward. So even if you're somebody who doesn't learn well from didactics, well, there's another place where you can bring cases and get some help, and learn from other people's cases as well, and buff up your skills.
Thank you.
Of course. Thanks. Lohati is recommending the Echo Adult Psychiatry series. Very informative and a great networking opportunity with other attendees, and potential to create a community of practice group. Absolutely. If you happen to come to the Adult Mental Health one, you'll have to deal with me again, because I get to be one of the faculty for that. All right. Well, I know we're running a little bit low on time. I just want to check in. Any last questions or comments?
Thank you. Truly, I can't find the words. You have just bent over backwards to make yourself available. You've dealt with our scheduling glitches, our registration glitches. You know, you've done everything you could possibly do to make this work. And I hope that the folks here today will spread the word about OPAL-A. And I hope that maybe we gather some momentum for our Southern Oregon counties to get behind OPAL-A. Sounds like Klamath is on board. Yay, Klamath. That maybe we can do something closer to home for Jackson, Josephine, Coos, Curry. So thank you
Thanks.
again, Dr. Betlinski.
Of course, and thanks again for inviting me into this space, and thank you to all of you for being concerned about our fellow citizens in the state and making sure that they get quality care. I really appreciate your time.
Awesome.
Thanks so
Thank
much.
you.
All right.